Hello, my name is Kevin Fernando and I'm a GP partner at North Berwick Health Centre near Edinburgh, as well as Education Director for GPnotebook Education. Now, the Faculty of Sexual and Reproductive Healthcare, FSRH, has produced some useful and pragmatic recommendations to help us in primary care support women of all ages with contraceptive requirements during this COVID-19 pandemic, as we cut back on non-essential face-to-face contact to reduce the risk of coronavirus transmission. It's well worth visiting their COVID-19 resources and information page at www.fsrh.org, from which I've drawn the information for this brief podcast. First of all, long-acting reversible contraception, or LARC. The FSRH has suggested that replacement procedures for recently expired LARC are non-essential. And given the current circumstances, the FSRH now recommends extended use of Nexplanon for 4 years and 6 years extended use of the Mirena or Levocert intrauterine systems. Replacement can therefore be delayed for up to a year to allow this coronavirus crisis to pass. After 4 years use of Nexplanon or 6 years use of Mirena or Levocert, all women should be counselled to use condoms and or add in a progestogen-only contraceptive pill. Notably, women aged 45 years at the time of insertion of the Mirena or Levocert intrauterine systems can be reassured that contraceptive effectiveness is preserved until 55 years of age, at which time contraception is no longer required. Importantly, for women using Mirena for endometrial protection as part of their HRT regimen, they must have their IUS changed at 5 years, alternatively switch to a combined HRT preparation. Furthermore, extended use of low-dose levonorgestrel IUS devices such as Jades or Kylena is not recommended, and women using these intrauterine systems should be advised to use condoms or add in a desogestrel progestogen-only pill such as Cerazette or Sorel at the end of the licensed duration of the IUS in question. Now, the expired IUS can remain in situ unless the woman wishes to become pregnant or has significant signs of infection or other serious adverse side effects. Of course, there will be many women who understandably remain concerned about the risk of pregnancy. They can leave their LARC in place and use condoms and or add in a progestogen-only contraceptive pill. Finally, the FSRH also recommend extended use of banded copper intrauterine devices, such as the TT380 Slimline. This can be used for 12 years now. However, the FSRH do acknowledge a very limited evidence base. In contrast, users of copper IUDs licensed for 5 years, such as the Novo T380, these women should use condoms or add in a desogestrel progestogen-only contraceptive pill after 5 years use has elapsed. Once again, the expired IUD can remain in situ with similar caveats as earlier. The FSRH do also usefully remind us that any copper-based IUD inserted over the age of 40 will provide effective contraception until 55 years of age. Next, what about women who are established on combined hormonal contraception? Well, the FSRH recommends that we issue further remote prescriptions to cover 6 to 12 months use without rechecking blood pressure or body mass index. For the majority of women, the benefits of this approach outweigh the risk of unplanned pregnancy. Similarly, for existing progestogen-only contraceptive pill users, the FSRH suggests it is reasonable to issue a further 12-month supply without face-to-face review. For those women on Depo-Provera, the FSRH recommends switching to a desogestrel progestogen-only pill without need for a face-to-face assessment. If there were no relevant contraindications to Depo-Provera, then the likelihood that there are no contraindications to the progestogen-only pill. However, we should remain aware of issues with adherence or absorption, and as previously, any concomitant use of enzyme-inducing medication could reduce the effectiveness of progesterone-only pill. If the progesterone-only pill is commenced up to 14 weeks after the previous Depo-Provera injection, no additional contraceptive precautions are required. Next, Cyanopress. Cyanopress is a progestogen-based LARC given by subcutaneous injection every 13 weeks and is self-administered by some women. And the FSRH suggests that these women who are self-administering can receive a 12-month supply without need for a face-to-face assessment or a blood pressure check. However, as many of you will be aware, there have been supply issues with Cyanopress and it may well be unavailable. Penultimately, for new contraception starters, the FSRH recommend we assess women remotely and issue a 6 to 12 month supply of a desogestrel-based progestogen-only pill. If the progestogen-only pill is not suitable or not acceptable, combined hormonal contraception can be offered after remote assessment for 6 to 12 months, but would require an accurate self-reported blood pressure and BMI. Nexplanon and Depo-Provera can also be considered, but as much information as possible should be relayed remotely before the procedure to minimize face-to-face contact with healthcare professionals. And finally, for emergency contraception, the FSRH recommends that remote assessment of emergency contraception requirements is prioritized as soon as possible after unprotected sexual intercourse. Insertion of a copper-based IUD should continue to be offered first line where possible to women meeting the criteria, and if any delay to IUD insertion, we should also offer immediate oral emergency contraception in addition to the IUD. For women who do not meet criteria for emergency IUD insertion or decline it, offer both oral emergency contraception and a 3-month supply of the progestogen-only pill with clear written and or digital advice about additional contraceptive precautions to be taken, as well as when to start the progestogen-only pill and follow-up pregnancy testing. So I hope you found this podcast helpful. Thanks for listening again, everyone. And once again, stay safe and stay strong.